Hello, everyone, and thanks for joining us for this marketplace room on partnership and engagement. My name is Ali Nergis, and I am an intern doctor at Istanbul University. And I'm Global Planning Committee youth member of Global Health Practitioner Conference. I have been given privilege to moderate this amazing session. This marketplace is definitely one of the most interactive events of the conference, as we will be listening to stories, ideas, and projects that organizations around the world have implemented related to children and adolescent health. I want to encourage all participants to actively participate, ask questions, and share ideas with our presenters. Please use the chat box to type in your questions and comments during the presentation. If time allows, we may ask all of them. Now we have three presentations, and the first presentation is A Legacy of Polio Eradication in Action, an experience of CORE Group Polio Project. For these amazing presentations, our speakers, Jitendra Awale and Dr. Roma Solomon from CORE Group Polio Project, India. Jitendra Awale is a development professional with more than 29 years of experience in various capacities in leading health, nutrition, and development projects. For the past 16 years as Deputy Director of CORE Group Polio Project. Dr. Roma Solomon is a medical doctor by profession with 40 years of experience of working in community health programs in India, Nepal, and Bangladesh. Since 1999, heading the Secretariat of an NGO consortium that works to eradicate polio and improve routine immunization in high-risk states of India. Thank you very much, and over to you, Dr. Roma Solomon and Jitendra.
So, greetings from Polio-Free India. For last 10 years, India is free of polio virus. This is despite neighboring Pakistan and Afghanistan are still having endemic polio virus transmission. By now, you must be curious why I am talking about polio when there is no polio for last 10 years. And everybody is disturbed or talking about this COVID-19 pandemic. India reported first COVID-19 case in last January. And in last 12 months, we crossed 10 million cases mark. But the silver lining is that our death rate is very low compared to other developing countries. As of today, there are less than 200,000 cases of active COVID cases. And best part is India started vaccination against COVID, and maybe by this evening, more than 2 million health workers are vaccinated with indigenous vaccines of COVID. So today, I and our project director, Dr. Roma Solomon, are going to share with you India's COVID-19 pandemic response, a legacy of polio eradication experience of CORE Group Polio Project. So it is a story of a strong political will of government. It is a resilience of the community, strong determination of civil society, and above all, a best community engagement. So please join me with this presentation. So in next few slides, we are going to describe to you strategies adopted by CORE Group Polio Project India in leveraging polio assets for the response of COVID-19 pandemic. And also we will discuss how long-term community engagement activities are useful in addressing health challenges at scale. Rather, I will say that by the end of this presentation, you will be convinced that community engagement should be integral part of any public health programs. So, as I talk about this CORE Group Polio Project, it is a USAID consortium of USAID funded consortium of NGOs currently working in 8 countries. We are in some of the very difficult areas for polio. We are in Afghanistan, South Sudan, Somalia, Kenya, Ethiopia, and Uganda, and India. We are working with host governments and UN agencies like WHO, UNICEF in those countries. In India, CORE Group Polio Project started its work in 1999, and we are working with 3 US-based NGOs, Project Concern International, Adventist Relief and Development Agency, Catholic Relief Services, and 6 national NGOs. Polio eradication is all about reaching to unreached children, building trust, engaging communities to make them part of the solution. This is what we learn, and this is what we are using every time. CGPP has its extensive social mobilization network in 12 districts of Uttar Pradesh and one district, new district in Haryana, that is very near to Delhi. My other colleagues, Dr. Harish and Dr. Arti from Delhi, will definitely know about this area, how their challenges and immunization and other health challenges. So, as a background, I will tell that last 20 years, CGPP has used this experience and expertise of risk communication and community engagement. We have created many networks of these community influencers. COVID-19 pandemic has devastated health system and communities across the globe without any discrimination. Rich nation, poor nation, developing nation, industrial countries, everybody has devastated their health system, their communities, their economies equally. However, during this pandemic, we have seen that polio assets are deployed to respond this global emergency in most of the countries, wherever polio network is actively working with government. CGPP, using its core strength and existing community level assets, initiated response to build confidence among communities to deal with the pandemic. And as I'm saying it, it is not only for India, but in all other 8 countries, CGPP is working for polio. This polio network is using for this pandemic response. And if my colleagues from other countries are here, they will definitely endorse what they are doing for this pandemic response. Our colleagues from WHO and UNICEF in India also are working with government to respond to this pandemic. For this presentation purpose, we have taken information from our administrative records and reports, meeting reports, our training reports, and weekly updates coming from the field. So what were our interventions that we are so much talking about? As I told you that first case came in January, but by March or mid-March, government and most of these development partners understood this problem and these challenges for this COVID, and government initiated so many initiatives like lockdown and restrictions on travel and so many other things. So at that time, CORE Group our project started a rapid survey among our field functionaries to understand what they understand about this COVID and what are the training needs. Based on this training need assessment, we developed a communication and training package that included pictorial messages and other materials, and we develop it so that it's easy to share through WhatsApp or other even simple messages also. And virtually we trained 700 community volunteers. All these volunteers are extensively trained for immunization and wash, nutrition and immunization. They are very good communicators. And about 5,000 community influencers were trained telephonically by our network. And these community influencers and community volunteers further disseminated messages about this COVID and how to prevent COVID and the facts about COVID, counsel vulnerable families. And I want to share with you that all these 5,000 community influencers or this community 700 plus community volunteers, they work free of cost. We didn't give anything to them except training. And even some of them prepared masks and distributed on their own to the communities. So this is the commitment from the community people. So what we did, the community confidence building process was reinforced. And as I told, that these volunteers were working for polio and other immunization, they have their success behind them. They have experienced and tested the success. So every communication they used to say, like we defeated polio, we will defeat corona too. So that was a confidence building measures that was done. So as a result, we reached more than 7,000 families, including about 2,000 suspected or confirmed COVID cases, disseminated prevention messages, stigma reduction messages, initiated practices like hand washing, talked and oriented immunization workers how to do COVID appropriate behaviors at immunization sessions, and how taught also to the caregivers to follow COVID appropriate behaviors at the immunization sites. And in this picture, you are seeing this community action group sitting in village and discussing about their issues because of COVID-19. And these issues are mainly about stigma. Many people were boycotting families, or many people were losing their livelihoods, and people were afraid to go for quarantine. So many issues were there like that. And these community leaders, they were like village heads, they were like a grocery shop owners, they were village teachers, and our staff, and also there were some health workers, community health workers were also there. So all together they discussed about how to support those families who are finding these difficulties. And even they went ahead and helped them practically by linking them to government facilities, to get them groceries, to get them healthcare, to get them proper quarantine facilities, so and reduce the stigma. So CGPP functionaries provided support to health workers also in micro planning and screening for COVID testing, and also counseled families who were refusing to go for testing or quarantine. We have stories or reports that initial few weeks, community was so scared because of lack of information or disinformation, or sometimes more wrong information, that there was stone pelting or to the community health workers. People even boycotted community health workers. They didn't allow community health workers to enter their village or their lanes in the urban areas. And at that time, our people, our staff, engaged with these local influencers, counseled them, shared with them the facts and different preventive measures and how they can support each other. And when community realized that yes, they should also start working with health workers, and they supported these health workers. And there are numerous stories and numerous reports that how these community action groups and community volunteers help health workers to support in this COVID-19 pandemic response, be it screening, or be it active case search surveys, or be it counseling to families to go for quarantine or testing. All this done together with the communities. So just to conclude, a strong community engagement established for polio eradication in last 20 years is still a living legacy. It is not just gone with the, like many projects come and go, and you can't find what is behind. But this is really sustainability model, I can say. And this community engagement is still we can use it for other public health challenges that we have proved here in this COVID pandemic. So from this platform, I urge government and donors to ensure that this legacy is nurtured and not forgotten once the pandemic gets over. So global community also can do advocacy. It is not in case of for India. Globally also, wherever we are in different countries, we can advocate with our governments and donors to support this kind of initiatives. So thank you very much. And any questions, welcome. And Dr. Roma Solomon is here, and my other colleagues, I saw other colleagues also joining, Reena and Manoj. They can also contribute to any questions or any clarifications you require. So floor is open for any questions. Thank you.
Thank you, Jitendra, for this amazing time management. We have 5 minutes for questions. Please ask your questions through chat box, and we can accommodate as many as them. If there is no question, maybe we can take some messages from Dr. Roma Solomon and other colleagues from CORE Group.
Okay, hi. So I think Jitendra has covered everything. We are a 2-decade-old program, so we are very much familiar with, I won't say pandemics, but it was like a polio epidemic when we joined, and we were able to talk to the communities and convince them. So we are very credible in the communities. We are very well known, and these influencers help us all the time. Without any financial support, they're very proud to have helped us eradicate polio from our country. So we thought this was a good chance for us when this pandemic broke out, that we were able to sort of go into the community and allay their fears, their anxieties. There was a lot of stigma, because the moment a person was diagnosed as having COVID, the medical officer would send an ambulance with the siren, with the police siren, and that would frighten everybody around, and sort of, people would start hiding. And we didn't want that. They didn't want to be quarantined or isolated or taken to a government facility. So with these kind of, talking to them, allaying their anxieties, providing essential services at their doorstep, giving them like solid help, what they need, medical care, food, these kind of things. So we were able to, sort of do a lot of things, and people then started coming out themselves for testing, and they were not so scared. Yeah. Thank you.
Thank you for sharing your thoughts with us. I don't see any questions right now. Thank you again for these amazing speeches. We have listened to the great story of polio eradication in India. It was definitely one of the great achievements of modern times. Globally, we can learn valuable lessons for COVID response, I think. Now we will continue with Mustafa Kallon and Mary Hallisey from GOAL organization. They will present adolescent perspectives on adolescent pregnancy and contraceptive use in Freetown, Sierra Leone. Mustafa Kallon is the country health coordinator for GOAL Sierra Leone and has over 15 years experience working in the public health sector. Mustafa is a holder of MPH and BSc in nursing. Maria Hallisey is GOAL Global Health Advisor and a public health specialist with over 25 years of experience of working in international development and humanitarian health programs across a wide range of contexts. Maria Hallisey trained as a nurse and midwife and has an MPH from the University of Pretoria, South Africa. Over to you, Mustafa and Maria.
Thanks so much, Ali. GOAL, as you've already mentioned, we both working for GOAL, and we a humanitarian and a development organization. We are presenting a research finding on adolescent perspective in pregnancy and contraceptive use that was conducted in 2018 in Freetown. Our research partner was actually Bill Melinda and Gates Foundation, and we did the research with population counseling. So the research itself really captured factors shaping adolescent reproductive health behaviors and explore social context and knowledge, and also look at the current status of service delivery for ASRH. We also look at the perception of mobile use and social media from the perspective of adolescents. This was followed by a hackathon which was like a 3 days event where we had adolescents and a cross-sectorial partners from both the private and the public, including the National Secretariat of Adolescent Pregnancy Reduction and Child Marriage. And we were there to actually validate the findings of the research and also to get more insights and provide ideas and solutions to the problems that we actually identified. Before we present the findings, we would want to actually just do a small quiz so that we will test our knowledge. And so we will put up the slide with a question. I will read the question. One of the options is incorrect. Identify the incorrect option and then put the relevant letter, not the entire statement, just the letter in the chat. So with that, okay, question 1. In Sierra Leone, 38% of girls are married by age 18 years. B, adolescents account for 20% of maternal death. C, adolescent pregnancy is not a problem. And D, the First Lady leads a campaign called Hands Off Our Girls. So you can put your response in the chat, and then you have 10 seconds, then we will be able to. Okay, I can see from the chat that majority of the people have actually chosen C, which is really the incorrect statement. Of course, teenage pregnancy is really a problem in Sierra Leone, as close to 30% of the adolescents become pregnant. Question 2, the key issues contributing to poor reproductive health outcomes for adolescents in Sierra Leone include A, profound structural exclusion and poverty, including the prevalence of transactional sex. B, gender inequality and inequitable power dynamics within relationship. C, cultural practices and social norms and perpetual gender inequality. And D, not enough sunshine and vitamin D. Again, from the chat, I see a lot of us have actually chosen D, and that is, of course, in Sierra Leone, we have enough sunshine. We have up to over 6 months of dry season. And the final question for now will be question 3. Many adolescent girls in Freetown, Sierra Leone, experience stigma related to use of contraception. B, never experience sexual violence. C, feel that mobile phones and social media are often a source of misinformation. And D, feel they do not have decision-making power within their relationships and cannot easily negotiate contraceptive use. Okay. Wow, I can see that all the responses have chosen B, and that is, of course, the incorrect statement. Of course, sexual and gender-based violence is really prevalent in Sierra Leone. So with that, I will hand you over to my colleague, Mary, to take you through the findings of the research.
Thanks very much, Mustafa. And yes, I'll just give a quick overview of some of the key findings from the research so that we have some time at the end for people to ask questions on this. So yes, this was qualitative research with focus group discussions with adolescent girls and boys from the age of 12 to 20. And we also included adult men from the age of 18 to 30 who had a female partner under the age of 20. So a wide group there. So the research findings identified 4 overarching themes that identify the perspectives on critical factors shaping reproductive health outcomes and contraceptive use. So these 4 themes included community social norms and the transition to adulthood, the social norms that influenced these adolescents. Gendered meanings around contraceptive use, what the difference between how meanings was different for boys and girls. 3, knowledge and beliefs about specific contraceptive methods. We had a look at their knowledge levels. And as Mustafa said, the use of conditions of access and use of mobile phones. So the first theme that we looked at there was on perceptions around issues of maturity, sex, and pregnancy. So decision-making around contraceptive use, we found, was obviously clearly situated within their broader social context. So the context that these adolescents lived within. And the key, I suppose, issues that emerged were around, or the key themes emerged were around values of obedience to elders, hard work, and doing their study, the gendered expectations of physical and social maturity and what that meant for them, the social consequences of perceived promiscuity from use of contraceptive, and coercive sexual relationships. So we found while physical maturity was a marker of a transition to adulthood for both boys and girls, this had a different meaning or implications for girls in particular. Sorry. So you'll see some on the slide, you'll see some quotations from some of the participants on that. And so you can see that no matter what age the girl is, once she looks mature, or physically mature, then it's a sign that she's sexually available, according to the boys. We found that coercive sexual relationships was a common issue raised. And the example here of water for water refers to an example from Sierra Leone, where adolescent girls can be coerced for sex in exchange for basic needs such as water, so underlying the sort of vulnerability and the impact of poverty for these girls. And of course, the social consequences of pregnancy and was different for girls and boys as well. With a girl gets expelled from school or her family, while boys experience less harsh implications. So the second theme then was around how girls and boys viewed or understood contraception, and we found a wide spectrum of views here. So from one end of the spectrum where contraception was viewed as something very responsible, that a girl was being responsible and planning for her future, to the other extreme where use of contraceptive was kind of considered that a girl was being promiscuous or that she was challenging the authority of her male partner. This stands out as an important finding because it suggests that there's potential to persuade more people to think about how prevention or contraception can be seen as a mark of maturity and for planning a better future. So the third theme was around the general understanding of of contraceptive methods, the different methods and their availability. And we found that participants' knowledge was actually quite high, but there were some misconceptions. For example, some mentioned male injectables, which don't exist in Sierra Leone at least, and things like traditional ropes, which is that are supposed to be a contraceptive method. So in terms of service delivery, provider stigma was also highlighted as a key issue that impacted on girls' uptake of services as well. If they weren't treated well by health workers when they went into the health facility. And then the fourth theme relates to the mobile phones and social media. So because we wanted to understand whether phones are a good way to reach young people, we wanted to learn about access and ownership of phones. So we found two areas of interest here, and that was the issues around control and surveillance and good and bad uses of phones and social media. So according to both boys and girls, the use of phones was highly monitored. So whether provided by a parent or a male partner, the purchaser had the right to monitor a girl's use of phones, whereas this wasn't the case with boys. And while the benefits of mobile phone and social media were highlighted and acknowledged, things like, it's used for communication, obviously, but also learning and accessing information for school and things like that. There were also, social media in particular was also seen as a source of misinformation or untrustworthy information. You can see some of the views expressed on this slide here, where you can see, where mobile phones play a part in control of girls. So you'll see some of the quotations from some of the male partners there, that it's common because, I want a lady, I will buy her a phone. So there's also a common sense that often there are overt trades involved in this. So sex for phones, or men would give a girl a phone with the expectation that she owed him sexual fidelity. So so that's a quick whistle stop of some of the key findings. So some of the views, some of the key points coming out from the research and the hackathon are highlighted here, summarized here. So the shift in expectations we need to shift expectations about sex and relationships to reduce the burden on girls and to reduce stigma on girls as well in relation to contraceptive use. The other one was around elevating the value of prevention or contraception, and to see it as a positive thing, that it's a young person being responsible rather than as a negative. Increasing the access of accurate information and challenging misinformation was also coming out strongly as a need, the need for trusted sources of information, and that information coming from different trusted sources. Reducing the cost and distance barriers for service, and also provider stigma, working or training of healthcare workers, for example, on how to provide adolescent-friendly services. And then finally, the safe mobile phone access, critical thinking about social media and information quality. So I'll just hand back now quickly to Mustafa to kind of summarize that in terms of how we use this research to work with partners and to design programming for adolescents. Thanks, Mustafa.
Yeah, thanks, Mauro, for that. And from the research and other work we've been doing, we've used this to actually, in collaboration with other partners, to really look at three main areas. One is on health system strengthening, and as Mary mentioned, the issue around training of healthcare care workers. So we were able to actually work with the National Secretariat for the prevention or the reduction of teenage pregnancy and child marriage to do an assessment. And then we were able to actually provide some support on providing some adolescent-friendly spaces as and how they were appropriate involving the community people. And so this we were actually doing with other partners. The second focus was really on social and behavior change communication. And we've been doing a lot of things using different channels of communications. And then we have our community dialogue sessions where we have both adolescents and community members actually discussing and finding ways of and planning how they would be able to actually address some of the social and cultural things identified that are actually preventing people, and also engaging key influencers, religious leaders, male champions, to actually also influence the social norms. And also leveraging the technology that is available to all to use, which the the key influencers and the adolescents themselves. And then the third area is on health accountability, which actually is looking at how we build the confidence between the service providers and the community people. And so we have the people-centered advocacy, which Goal has actually used in Uganda, and we piloting this in Sierra Leone to actually, again, bring more. So with that, we want to leave it there. If we have questions, then probably we can discuss more.
Back to you, Ali.
Thank you very much. Thank you very much, Mari and Mustafa, for this amazing presentation. We have 3 or 4 minutes for questions. If there is any question, you can open your microphone and ask directly to our speakers, or you can use the chat box and we will try to answer them. Well, while waiting for any question, I must say it is definitely a well-organized piece of research. Thank you very much. As a youth, personally, I am happy to see that global organizations give importance to our thoughts, needs, and challenges. And I think in Sierra Leone, adolescents have very different challenges and needs in context of sexual and reproductive health and rights. And maybe just for last some last thoughts from you, Mari and Mustafa, if you want to share personally, what do you think about this research process? What was the most interesting, or I don't know, most interesting part of the research for you personally in your life, or maybe?
I think I'll leave Mustafa lead on that one.
Yeah.
Do you have any thoughts, Mustafa?
Yeah, so thanks so much, Ali, for that. I think for us, the validation process that brought actually the adolescent to look at the findings, validate, give more insights and about really the things that are affecting them was really interesting for me, and also the participation of both the private sector and the public partners really working around adolescents. So we have like ICT companies like mobile phone companies also preferring some solutions on how they will be able to leverage on ICT to reach out to adolescents. For me, that was really interesting, and also hearing from the adolescents some of the solutions they think will be really, I think that was really, really interesting for me.
Thank you very much. Thank you for sharing your personal thoughts. So last but not least, we have another 3 esteemed speakers. They will present breaking down silos to transform care and unlock potential for the smallest and most vulnerable citizens of the future. First, we have Nina Katka. Dr. Nina Katka is a pediatrician with over 30 years of experience in clinical and public health. Dr. Katka was a team lead for newborn health for USAID's Maternal and Child Survival Program. And she's currently newborn focal point for USAID's Momentum Country and Global Leadership Program. And then Dr. Maria R.T. is a professor and head of the neonatology department at Dr. Amal Hospital, New Delhi, and was an expert consultant in developing current WHO standards of newborn care in 2019, as well as the revised guidelines. And lastly, Dr. Harish Chalani is a professor and principal consultant in the Department of Pediatrics in New Delhi, India. Dr. Chalani trained at Harvard School of Public Health for improvement of quality in health services and is published in various national and international journals. Over to you, Dr. Nina.
Hello, thank you, Ali. And I was trying to And okay, can you see me and hear me now and see the screen as well?
Great, it's great.
Okay, thank you. So it was very interesting to hear about the polio work and reflect back on what's happened, and also the adolescent work. And I'm now going to take you to a point where we are now getting to the smallest of them, the most vulnerable, actually, to talk about them, because if they don't survive and if they don't thrive, none of the others matter. So with that, let me see if I can move my slide. Okay, so what we want to do when we are together today is just talk a little bit about the small sick newborns and refer to the recent standards released by WHO. These are babies who are the smallest and the sickest and are in the hospital care. These babies contribute the biggest to the newborn mortality, and all countries that have signed up for the SDGs need to ensure that they survive. But it's not enough that they survive only, because they need to thrive. That means they grow into able citizens and are able to lead their lives well. So to do that, we want to interact with our two champions who have come from India, who are staying up very late out there, and they're going to talk about examples of what they've been doing. These are the standards, and I don't want to go into the details. There are 8 of them, but today we will focus on the 6th. And the 6th one is primarily because this is what we think is the foundation of all care. This is the standard which talks about emotional, psychological, and development support. And it's emotional, psychological, and development support for the baby. Yes, even for the baby and their families. And it's so essential that the mother, the father, and any caregiver gets those support. Otherwise, we will not get there at all. Now, this is something that has been happening in high-income countries. They have been making efforts to engage the family, work with them, but we haven't been able to do as much in low-middle-income countries. So today, that's why it's so important that we talk to Professor Arti Maria and Professor Harish to Chilani and learn about their work out there. So that's what we are going to do. And I'm going to we are going to have a more interactive, I'm going to just ask some questions, but I would also request people to chat in their question. It's an opportunity. We are not going by any format per se, but so if you have questions directly, please chat in your box. So my question first to Arti actually is, Arti, I know you're one champion who's done a lot in India. Can you tell us what actually led you to do that? Why did you think? Because normal care, inpatient care was happening in your facility. And then something happened and you were seeing things that made you think differently. So over to you, Arti.
First of all, I want to thank you, Nina, and the CORE Group for giving us this opportunity and acknowledging such things which I'm not sure I deserve. So anyway, I straight go to the matter because I suppose we are not supposed to go beyond our time. Okay, I come from India, from a public health facility, which is called Ram Manohar Lohia Hospital, popularly called RML Hospital. And we are in the capital city of India. And I look after a unit. I moved there to this unit in year 2007 in a setting of 16-bedded referral neonatal unit, which was facing severe HR constraints. And I would like you to witness what kind of a neonatal care that we were facing. Nina, please. Nina, you have to be a bit vigilant.
Yes, I am trying, but it's refusing to move right now for some reason.
So while you try,
and I'll keep trying.
While she will give you a picture of what it was, I would tell you, amidst the severe HR shortage constraints, we faced compromised quality of care. As you can see, the newborns being absolutely looking as if, and I am not ashamed to say that because this may have been a situation at many places. Swellings, IV swellings, misplaced tubes, wet babies, incessant alarms, there's nobody to take care except the nurses are overburdened. So obvious compromised quality of care. There was no attention to the developmental needs of a vulnerable baby who's going through a critical period of brain development. There is a obvious lack of nurturing care and early bonding opportunity with family. There is a lack of continuum of care. And what you see as a paradox, the parent attendants outside in a silo, they are waiting outside absolutely dejected, anxious because of separation anxiety, sickness anxiety of the baby, and they have a lot of unmet needs due to lack of information, guidance, and support and communication. They have unattended psychosocial needs, and due to limited involvement in care of their own small and sick newborn babies, just because they can't get into the nursery, they have only visitation hours in which they can peep into the baby's condition. There is a lack of competencies and skills that follows into an inevitable fallout of possible lack of continuum of care, and there is a risk of severe morbidity and mortality post-discharge. This actually led to a thought, can we start engaging this potential HR in 2 of the waiting parent attendants as nursing aides for their own babies, just to improve quality of care? At least they'll change nappies, they'll do a lot of things. Yes, that was the genesis of family-centered care in its most rudiment ways. And that I want to show you, we started getting the parents into the nursery one by one and trying to tell them and teach them about little things that they could do as nursing aides. Thank you very much.
Thank you. Very impressive. You know, I wasn't able, I'm sorry with the slides. It's been very difficult. There's been internet problem in our area. And so you just got a glimpse of what's happening, and the slides will be there. We are going through this rapidly. But I'd like to move on to Harish. Harish, you had a similar situation in your facility, another public health government-led facility where you wanted the mother to be with the baby. And that's what led to your next one. So let me hand over to Harish. Harish, over to you.
Thanks, Nina. I am just taking forward from where the Aarti has left actually, and these are our units, and globally, not only in the developing nations, globally, what happens is that a mother with a baby admitted in the NICU, a mother stays in the postnatal wards or in their private rooms. So what is happening is that she spends very little time with the baby. And on an average, we have seen in our own unit where we had been, saying that mothers should come to the nursery every 2 to 3 hourly for feeding. But we have seen they come only for 3 to 5 hours a day. You know what happens when the mother comes for a short period, that too intermittently during the daytime, and there is no additional space for the moms who have just delivered. So what happens? This compromises the kangaroo mother care and the breastfeeding rates. Both are key interventions for the survival of the low birth weight and sick babies. So both these interventions when we talk about, and the secondly, what Aarti just mentioned about the workload of the NICU staff. So if mother can be engaged in that, then definitely there are many tasks which she can do, like changing the diapers or cleaning the baby or assisting in the feeding. So because of these challenges that forced us, can we do something? So maybe that's what we brought the concept of mother in NICU. So in that we have created the bed of the mother next to the baby inside the NICU. So what you are seeing, it's a 12-bedded NICU where each NICU bed is with the mother's bed inside. So mother and baby, they are cared together 24/7. And this unit has got all the facility of level 2 newborn care. You can see the central oxygen. There is a CPAP unit, radiant warmer. So all level 2 care unit facilities are there in that unit. So in that, what you see, mother and baby, they are together and they are cared together actually.
So Harish, if I may ask you then, just for our audience, I've been privileged to have visited your facility. I felt really impressed by what I saw and your efforts. So maybe you can take us through what exactly happens when a small or a sick baby is born in your hospital. If you could take us through that journey, we'd be grateful.
Yeah, thanks, Nina. So what happens the moment the baby is born? Immediately, baby is put onto the mother's abdomen, and from there, if the baby requires the NICU care, both mother and baby, they are taken or transported to the NICU. You can appreciate in the first photograph that she is being transported with the mother's chest, and then she stays with the baby stays with the mother 24/7, and till discharge, baby and mother, they are together. The another thing which is very good, which we have got it here, the concept of couplet care, where you can see that obstetricians and pediatricians, they both take the round, and in fact the obstetricians, they are daily coming to the newborn unit, and they see and involved in the care of the mother and baby together under one roof with good cooperation. Secondly, the care of the mother is being provided by the neonatal nurse. She has been trained in that. And now what happens once the mother is there 24/7 with the baby? It improves the opportunity for the kangaroo mother care and breastfeeding rates. You can watch that even the tube feeding is being provided in the KMC position. So in fact, the kangaroo mother care duration has gone up to 16 to 20 hours, particularly in the first 72 hours when the babies are critically sick also. So that improves the opportunity of the care.
Thank you.
And maybe if you can put it in the next slide, actually, the mother has been now, the role is also caregiver. She changes the diapers, and it is a developmentally supportive care which the mother is providing.
So it's the loving, compassionate care that the mother does instead of a provider, and it helps both ways. It helps the provider because it takes off mundane tasks and it releases her to do more specialized care. So maybe I can turn to Aarti. Aarti, similarly, in your unit, tell us about what actually happens, because it's a big crowded hospital. I've been there. I've seen what it is like out there, and yet you've managed to introduce something that is amazing. Over to you, Aarti. Can you just take us through that journey?
Okay, taking it forward, we actually developed indigenously a culturally sensitive audiovisual training tool to standardize the training and capacitating of the accompanying parent attendant, so as to accompanying parent attendant who's accompanying their own sick and small newborn to partner with the healthcare provider in care of their own newborn. So the training of the training tool is compromised into composed of 4 sequential sessions or modules. The first one is about the entry protocol, duly giving importance to do no harm. With that intent, we want to teach the mothers about hygiene, hand hygiene, personal hygiene, how to don, how to get entry into the nursery. The second one is addressing the missed developmentally supportive care, opportunity, which otherwise the mother is not there, so baby does not get. And this provides an opportunity for nurturing care. So mother is taught about sponging, about cleaning, about nesting, about positioning, about handling, about expression of breast milk, assisted feeding, and dealing with the early childhood development, and then interacting with the baby. The third session is into the kangaroo mother care. And the fourth session is about preparation for discharge and care at home, to form a continuum of linkage at home. And that also tells the mother how to pick up the danger signs and seek early care seeking in case of sickness. Now, how did we institutionalize the family-centered care? The process, the journey really. A sick baby comes, he's accompanied by his parent attendants. induction session or sensitization session is held with the family to identify a primary care provider. Number 2, the daily trainings are scheduled to train the mothers, then either by the audiovisual training module as well as with the demonstration and practice hands-on. For example, hand washing, and I'm proud to say our mothers would demonstrate hand washing much better than and very fluently as compared to our doctors also. And then the mother gets into the realm of supervised learning and performing tasks being supervised by the nurse. A very interesting part has been peer-to-peer learning by a mother who has been there for a longer time. And she very empoweredly, she would teach the newer mother with the skills that she has learned, and it is fantastic.
Aarti, we just have around 3 more minutes to complete. So if
the mother then gets into a state of independent doing, and then she is at the time of discharge, they are counseled to develop a linkage of continuum of care at home. That's it.
Thank you. So I would like to ask a final question. You know, this is amazing. This is the need of the day, done in high income countries. Can you, in just 1 minute, Aarti, tell us, or maybe we can begin with Harish, what is your plan for scaling this up in India? How can it move from one hospital to every hospital in the country, wherever sick newborn is cared for?
To convince our own colleagues, the medical personnel and the administrators. And that will come only through the evidence once it is on the public domain. So that was going to be the first step. Second, I think concern is of the most of the people is that bringing mother together with the baby would cause infection. So, but bacterial flora, the maternal flora is protective. So that's what we have to provide the, convincing them and third important thing is the challenge which I feel, which is there, apart from convince the people, is the care of the mother. So that portion, and lastly, I would say accountability of the healthcare provider. So people are apprehensive. They think that mother should not be there 24/7. So with the baby, so that's why there had been a reluctance, not only in the developing nation, but also in the developed nation. If we see the history, there had been an issue of the accountability.
So how are you convincing your leaders or other facilities in India? What's the vision for your MNICU?
So what we have done is now we have got the evidence. So it's there going to be shortly in the public domain. So, and once you provide the evidence to the people are going to do that. And Government of India has already, based on the interactions and evidence which has been provided to them, they have sent the advisory already that all our future units are going to become the mother in NICU type of the units.
Thank you, Harish. Thank you, Harish. That's okay, go ahead. Because I wanted to give Aarti just a few seconds to talk about how India has taken family-centered care to scale, if I may. Sorry to interrupt.
Okay.
Aarti,
No,
over
I
to
think
you.
it's Aarti.
Should I?
Yeah, just where is FCC in India?
Okay, so we saw how it started from a modest conceptualization of parental involvement as just passive nursing aids to help overcome the severe HR shortage. Then we understood the fringe benefits, and then we tested it in a randomized controlled trial, created evidence to demonstrate not only no harm, but also definite benefits like improved breastfeeding rates, improved KMC rates, shorter duration of discharge, etc. We moved into structuring this approach into an implementable model. And that's how you saw how we implemented it. This was pilot tested by the government with the help of NIPI in 5 districts of 4 states of India. And with encouraging results, and it was a well accepted and feasible model, it was then accepted into a national health program.
Thank you, Aarti.
We are now into 120 districts or more.
I know, that's congratulations. That's fast, such big work, really, I think. So the bottom line is generate local evidence, be champions, move it forward, and the country can do it. So if we can see this evidence from India, I think this is an inspiration for other countries too. With that, I stop actually. And thank you, everyone. We'd like to call everyone to a Momentum Market session, virtual session at some point later. Please join. And I don't know whether we have time for question and answer. Please type it in the chat box or just connect with any one of us. We will be.
Thank you, Nina. Thank you. We don't have any time for that, but I can see from the chat, people are really inspired from the work in the India, and I am also fascinating. Thank you very much, all researchers and practitioners. And this is the end of our session. Again, thank you to all presenters and our amazing listeners, and see you in other sessions and plenaries.
Thank you. Thank you.
Thank you very much.
everyone.